Good afternoon. My poster podium is Consensus Building in Treatment of Nasolacrimal Duct Obstruction with Concomitant Cataract. I have no financial interest. We all know that the presence of ipsilateral NLD obstruction is a risk factor for endophthalmitis, so it is pertinent to do preoperative syringing. However, there were some reports which suggested that preoperative syringing is not necessary, only Roplus can do, though a later report from a Arvind group suggested that lacrimal syringing should be done in all cases. So we have certain research questions. One of them is answered, syringing has to be done. Now, if there is NLD obstruction, what to do to treat or not to treat? And if we want to treat, then what should be the treatment? So the current scenario is there is a definite lack of protocol in the treatment of NLD obstruction with cataract. Our parent body has come up with ways and means to prevent intraocular infection, and these have evolved over the years, but still about the syringing and Roplus there are certain uncertainty. So the purpose of our study is it aims to generate a consensus in the treatment of NLD obstruction with concomitant cataract. It is a retrospective study over 1 year period. All patients undergoing cataract surgery were included. Lacrimal syringing was done in all cases. NLD obstruction treated or not treated was noted. Post-op endophthalmitis, if any, were noted. So the results show in 1,679 eyes, 4% of the patient had blocked NLD. The type of regurgitate was also seen. 31 had clear fluid regurgitation. So NLD obstruction found in 4.34% eyes. 20% of patients having NLD obstruction did not complain of epiphora. 8% of patients having patent NLD, however, had occasional to frequent epiphora. The choice of treatment was DCR, DCT, or no treatment, and it was based on the general physical condition of the patient, the amount of vision loss, and affordability. One eye developed postoperative endophthalmitis with a patent NLD. In the discussion, in Indian scenario, lacrimal and cataract surgery, a study said that 7.9% of surgeons feel that pre-cataract screening is not required, which is surprising. A later study in the COVID period, however, has said that the rate of post-op endophthalmitis is same or comparable whether we are doing pre-op syringing or Roplus. A study from Brazil has said that 78% of the surgeons feel that NLD needs to be unblocked prior to cataract surgery. So in a country which has a hugely successful Ayushman Bharat Prakalp, however, sadly, DCR is not included in that Prakalp. So do you think that a patient having asymptomatic NLD obstruction warrants treatment just because he wants to undergo cataract surgery? So we need to give a consensus, and our recommendation is we do syringing in all cases. If it is patent, go for cataract surgery. If it is not patent, note the type of regurgitate. Mucopus regurgitation, go for lacrimal surgery. If it is mucoid, then we have to take the history into consideration. Discharge present, go for lacrimal surgery. No discharge, go for cataract surgery. If the fluid is clear fluid, we again have to take the history. Symptomatic, go for lacrimal surgery. Asymptomatic, go for cataract surgery. The limitation of our study is the retrospective design and small sample size. So we conclude that not all eyes with NLD obstruction needs treatment, and in a country which is overburdened with medical health system, needless cataract surgeries should not be done. Only symptomatic NLD obstruction, purulent regurgitation needs treatment. Thank you very much for your kind attention.
Topic which we also face in our OPDs.
I know.
But I think routinely, when I was a resident, we used to do syringing in every pre-op patients. But over the years, this trend has stopped, and now we only follow the Roplus or the symptoms of the patient. If they have watering symptoms, then we try a Roplus, and if Roplus is positive, then only we consider. Otherwise, routinely, we are just going ahead. Everybody is. If
we are doing syringing 100 of
Madam,
surgery.
the
Even
Arvind study.
Surgery, we do syringing.
Yes, the Arvind study had 8,000 cases reported by Dr. Usha Kim, and she has seen that Roplus, even if it is negative, it does not suggest that NLD obstruction is not there. So syringing, they have recommended that syringing should be done.
Comes to you today, you have to operate tomorrow. tomorrow. So you do syringing
We
on
do
the same day?
syringing. We
In
do
north side,
syringing.
I can vouch for it. I am also sitting in a tertiary care center with so many. We are not doing syringing
our
because they
northeast-
say that syringing sometimes introduces infection which was not there. You are unnecessarily introducing infection one day before. Yes, betadine cleaning of the furnaces before the surgery, one day before antibiotics, those are being followed. In Delhi, in our side, I can vouch for it that nobody is
But
doing
in
syringing.
our
Because
side again,
Especially
it
one day
is-
before
I
to-
think because of the
We have
humidity,
not
our
seen
side
any
is
of
again,
this kind of patients.
our
having
side is
syringing
again
of
humid.
dermatitis
Regional
because of
variation is there,
lacrimal.
so
Yes,
I think
our side is
variation is
humid,
there.
so we do
Yeah.
syringing in all cases,
Yeah.
and we find NLD obstruction.
I said, when
just
we were
want to
resident, we
ask
were
a
doing
question.
I
camps maybe.
I think
up
north
maybe.
is very dry, that's why NLD obstruction is little
I
less.
just asked you a question. You said that Ayushman Bharat is not there in
there,
lacrimal
it
surgeries,
is
DCRs.
No,
In which
DCR,
area?
I will just show you that
DCR
again.
with
In which
intubation is
area
there.
is
Yes,
not available?
yes.
It
I
is
know.
available.
DCR
Ayushman
with
Bharat pays
intubation
for
is there,
DCR
but
in Ayushman.
Oh,
just
but no,
standalone DCR
can
is
you
not
please
there.
give that slide again? I'll show you the screenshot of the
Because
package.
PMJY gives money for DCR.
It is available, canaliculodacrocysto if you do, then that is included. And another they have written is dacrocysto with silicone tube or
Yes,
stent,
intubation.
and they are asking for
The reason in the-
invoice of implant. They are
Yeah,
asking for
that's good,
invoice
na?
of implant.
Then we have to give the implant. That's good, na? But it is available.
But
It is
I
available.
mean, we have to do canalicular DCR. Simple DCR is not
No, they
included.
are giving.
They're giving.
External DCR also they are giving.
Okay.
They're giving.
Even clear fluid, you can go for a microbiological profile
Yes.
because of the risk factors of endophthalmitis. So if it occurs, then there is no protocols or laid down by the government or any society. So to be on the safer side, always go for the surgical procedure, or you can go for a microbiological profile. And surgery has to be done within a week or 10 days. It should not be like today you have got clear fluid and patient is coming after 1 month or 1 week, and you are going for directly into the
So
surgery.
there is a variation in
Yes,
the.
so-
We are not doing it. हमारा सब ठीक चल रहा है.
I know.
Yeah. So
I can't say that.
always be in the
But
safer
it
side.
is definitely a very prevalent issue.
And even in the partial block or anything like that, those things you can just make it that yes, he can go for a cataract surgery if it's clear fluid
Yes.
and partial block. Still, you have to go for a microbiological profile
Yes.
to be on the safer side.
Thank you, ma'am. Thank you, sir.
Debatable issue.